Okay, welcome to Spine Conference. We're going to discuss flat back deformity and basically adjacent segment stenosis. So I think it's important to go over difficult, interesting cases because you learn from them. So this man's 67. This is actually him. His chief complaint was low back pain and severe bilateral sciatica. I I had been. Did you meet this guy, Preop? I had been watching him for a year, and he did not want the surgery because of his medical like comorbidities and his age. But he finally just gave in. He couldn't take it anymore. And I told him the surgery was a big surgery. But basically, he had low back pain, bilateral sciatica, and he couldn't walk. He had had previous surgeries in 2010, so 8 years ago, an L4S1 fusion, which is typical. Then he got adjacent segment degeneration L304, and he had a revision L3S1 fusion in 2013, 5 years ago, which went well. Then he kept getting problems in his spine above adjacent segment degeneration. He had fractures of both L1 and L2 above his fusion in 2015. That was treated with kyphoplasty. So his past medical history, he has colon resected for cancer in 2017 with good margins. He has COPD, atrial fibrillation. He had a history of a DVT. He was on Xarelto, and he's chronically anemic. His starting crit's 25%. And he's had a full workup for that, and they assume it's just he's losing blood out of his gut. So I called the hematology, and they gave him an iron transfusion, and they also transfused him blood. And I asked if he can get Epigen. Did I tell you this? I asked to get Epigen, and basically Medicare won't pay for it if you have normal kidney function. But Epigen would have been great for this guy because it would have given him a blast of of um, the ability to grow blood cells. So in physical exam, he's 6'3". He's tall, 219 pounds, and you can see a side view. So he has no deficits, but walks with a crouch gait. So what are your thoughts about the just the stance? Any thoughts? Yeah, he's forward. Yeah, he's pitched forward. So here's a front view and a side view. And what are your? So the front view looks normal. AP view. Lateral view, what do you think of the lateral view just off the top of your head? Normal lumbar lordosis is gone, but he also, if you look on the far right, I mean, he's basically from T12, from T12, L1, and L2, you should be straight. So basically, he's got, you can see on the side view, L3-1 looks pretty, well, yeah, L3-1 looks pretty good. We're going to call the bottom level S1. It looks like L5, but it's fused, so we'll just call it S1. That's what everybody's always called it in his history. But from T11, T12, and L1 should be straight. And you can see he's not straight. He's basically kyphotic up top. So just as a review, on the left he has pedicle screws from L3-1. On the right, just L304 because he had a revision L304 fusion, and the surgeon just chose to remove the screws on the right, the bottom for some reason, and not on the left, probably because it was just difficult. He felt it wasn't worth it. I didn't do that. I didn't do any surgery on him before, and they were done elsewhere. And he had interbody spacers at each level, and he's solidly fused at those levels. So just what should somebody look like on the side view? So um, the just the ballpark levels. L3 should be horizontal to the floor, should be straight. Um, from thoracic spine should have kyphosis anywhere from 10 to 40. I mean, the ballpark number I use is 35. I don't know. I mean, there's a big variance in like how much the degrees, but that's what I use. Lordosis is somewhere between 40 and 60, and 55 is a typical lordosis. And if you drop a plumb line or sagittal vertical axis, a plumb line from the middle of the C7 body, it should hit the sacrum posteriorly, like the back part of the sacrum, normally. Now, most people basically lose their lordosis as they get older. And do you want to comment why? Do you know why? Like I've lost my lordosis. Yeah, so it's very, very common for your discs to deteriorate as you get older. I mean, almost everybody, like 85%. And most of the, we're going to go over this, but most of the lordosis that we have is in the lumbar spine, specifically L4-S1, half of the lordosis. And that's the most common areas to get uh, degenerative disc disease. And the reason why it has the most lordosis is basically, my theory is that we were not, I haven't told you this theory, we're not evolved to be standing upright. If you look at every other creature in the animal kingdom, all the other creatures walk on all fours, but we walk on two legs, so it frees up our hands so we can, make tools, etc. When we're like cavemen, etc. All of that lordosis happened to L4-S1. So half of our lordosis at L4-S1. So basically, I don't think the spine was designed for that. So as we get older, that is where we deteriorate. There's where there's a lot of motion and there's a lot of lordosis. So we deteriorate L4, L5, L5S1. So we all get flat back as we get older. And what happens is people get degenerative disc disease, whatever problems in the lower back, and they have surgery there. And when the surgeon fixes it, the surgeon, he or she, just fixes it in situ, just doesn't try to recreate lordosis because first of all, it's very, very difficult. So he just fuses it, the doctors fuse it in situ, and that's why everybody has flat back deformity, lumbar spine. It's just because that's what happens to people. And if the patient gets adjacent segment degeneration like this guy, then they get kyphotic. Basically, there's a lot of stress on the top, and they get kyphotic at the top. Okay, so like how we should stand, this is military posture. So the head should be over the pelvis and the hips and the feet. And my opinion is this, the reason why this is military posture is because it's so balanced that you can stand like that forever. And the military knows this. So if you stand at attention, you can do that for 12 hours because you're balanced. If you're pitched forward, here's another. Here's like this woman is pitched forward, and she's not going to be able to stand like that for very long. You can just imagine she'll get tired. And that's how this guy walks all the time, 24/7. So that's why he's just exhausted. Like he's just he's not walking well. The other thing, he has hip flexion contractures, and the reason why he has hip and knee flexion contractures, he wants to look horizontal. He doesn't want his face heading down. So he squats a little bit, and then it gets stiff. And then that contributes to this whole problem. So what I do pre-op is I have everyone lay down on the table flat and see what they look like. And if they can lay flat, back of the head, buttocks, and feet, and the hips are can fully extend, I know that they're a good surgical candidate because we don't have to worry about hip flexion contractures. So some people have fixed hip flexion contractures, say 20, usually it's around the bad ones, 20, 30 degrees. You have to fix those with either physical therapy to stretch them out or a total hip replacement. So this guy didn't have that, luckily, but the severe cases have that. So, and you can't really tell, you can't really assess the hips unless you lay the person flat. And some people never lay flat. Like, can you lay flat, totally flat without a pillow? Okay, so you're, it's yeah, me too. When I lay down, I test myself. When I lay down on the floor, it's not easy. It's not easy because you get arthritic. And so it just goes to show you you're losing some of your typical lordosis, and that's a not normal posture for you. So it's difficult. And you imagine if you're 70 and you have all these contractions, it's real hard. So that's how we figure it out. So the other chin brow angle is another ankylosing spondylitis, like you assess, like where's the patient's face. So this is pelvic incidence. So pelvic incidence is a description of the pelvis and the shape of the pelvis. And we're going to go over this guy's pelvic incidence. So some people, everyone's pelvis is made a little different. It's basically the sacrum as it's associated with the hips, and people have different shaped pelvises. And some people's pelvis is shaped so that their spine is easily straight, and some people's pelvises are shaped where it's difficult. And I'll show you the difference. This is just a way to measure it. Basically, you take the top of the sacrum and then draw a perpendicular and then put a dot in the middle of the femoral heads, and then you use the vertical angle and you assess pelvic incidence, sacral slope, and pelvic tilt. I'll show you this, guys. So this is a normal lumbar spine. You can see most of the lordosis is L4-S1, and um, uh, from T12, L1, L2, it's straight. Should be straight. And the shape of the the shape of the pelvis, the uh, orientation of the femoral heads and the sacrum, which is all fixed. That's just like a bone. That that basically sets where the patient stands because it's all fixed on the base. So we'll go over this guy. This is our patient now. This is him standing, and his pelvic incidence is 62, which is almost abnormal. Like that's like, and this is like one study. He's got a very high pelvic incidence. And what does this mean? So this is on the left. It's a um, low pelvic incidence, and on the right, it's a high pelvic incidence. And the difference is if you have a high pelvic incidence, which is our guy, you need a lot of lumbar lordosis to be straight. You see that? Mm-hmm. But if you're low, you don't need that much lordosis. So you're not asking your spine to change its shape much. So what happens is if you're born like that with a high pelvic incidence, you're probably at risk for these problems for flat back deformity because of the way your pelvis is shaped. So, and that maybe that's why our guy keeps getting a problem because he has a high, and there's no way to fix the pelvic incidence. That's how he's made. Yeah, shape of his pelvis. Yeah, when he was born or when he was growing. This is just a couple things. So if you measure from L2 to L4, he's got 30 degrees of kyphosis, and it should be like slightly lordotic. So he's got a significant deformity at the top of his spine, mostly due to these fractures that he had at L1 and L2. So again, here's his lumbar. You can see the fractures at L1 and L2, and they. Do you think he was fracturing as in from the degeneration had his spine had compensate and that cause a fracture? I'm not sure. I think it's just the stress. It's just the stress of basically you have a fixed thoracic spine because his thoracic spine is probably very stiff because he's an adult, like an old man, elderly man, and everybody gets osteophytes. So it's the thoracic spine is very stiff. Now the lumbar spine is very stiff. All the motion is at T12, L1, L2. So he basically stress. Yeah, yeah, stress. So and he's osteoporotic. He probably doesn't exercise. He doesn't exercise, and his bones are weak. And the combination is like a terrible combination. He just broke his spine. So it kind of makes sense there. And here's flexion extension views show no motion. So he's basically very stiff, and the one disc is gone. You can see the L2, L3 disc is totally gone there from being deteriorated. So here's the MRI. So what is the most obvious finding on the MRI? We'll call the top screw L3. Yeah. Yeah, you can see the thecal sac is like really stenotic, and it looks like disc material, doesn't it? Looks like, I mean, it's got to be disc, and there's no rooms for a thecal sac. You can see, actually, you can see the thecal sac. You can see the nerve roots kind of bunching up where they're compressed. So it's severely stenotic. And you see on the right side, he's at his hypertrophy of the facet posteriorly. So anteriorly, he's got this huge disc herniation. Posteriorly, hypertrophy of the facet, and the combination is severe neurological compression there. Yeah, it's a very good MRI, actually, good quality MRI. But you can imagine the amount of pressure on the nerves. And then again, here's a T1 weighted image, and you can see just the same thing, this disc and severe stenosis. So this is him at L2, and you can see the thecal sac, and the conus is about to end there. And he sort of has small pedicles, which is not good for surgery. But like looking at the pedicles is one of your responsibilities pre-op. And you can see the size of the thecal sac. And here's the thecal sac at L2, L3. There's like almost no room for the nerve. You see the black disc, very large blast disc, and almost no room for the nerve roots. So he has severe stenosis at L2, L3. And this is a little farther down, a little bit past the screws. This spinal canal is wide open. That's what it should look like. And then a CAT scan at the same area, which, I ordered the CAT scan just to rule out non-union and look at the bone, and also look at the bony anatomy, the pedicles, and also the screw placement. All the screws had good placement, but you can see this disc is calcified, so it's going to be difficult to get out. and tease it off the thecal sac. But the other interesting thing is look at these massive osteophytes anteriorly. So he's got these huge. This thing has been going on for years. You can see it looks almost like a Charcot joint, like a Charcot arthropathy. The bone is trying to remodel itself. You can imagine the bone is trying to remodel itself and stabilize this segment. And the resulting osteophytes from trying to stabilize the spine compress his nerves. So here's a coronal section. You can see the old screw holes that used to be, but a nice solid fusion. And the sagittal cut shows, you can see like the story, this really degenerated L2, L3 disc here, and the cement trying to stabilize it, and this calcified disc. And this is a nice example of that calcified disc. You can see on the CAT scan how obvious it is. And the MRI, you don't know if it's soft or it's hard. So the CAT scan gives you a lot of information that is not obvious, I think. So the problem list in this guy, and here's the other thing I didn't discuss is anterior sagittal vertical axis. You see, I drew arrows of plumb lines. The front one is from C2. The next one to the left is C7. Again, that should be crossing this back of the sacrum. And then the other one's T12. So, I mean, he's really pitched forward a lot. And that is exhausting him. And you need a standing view to assess these. So the problem list in this man is basically severe stenosis at L2, L3, really severe. Then he's got kyphosis at both L1 and L2. Those bones are really deformed above an L3 S1 fusion. So that's the basic problem. So since both the stenosis and the deformity are at the same area, I mean, I think you have to do a pedicle subtraction osteotomy. You can't just fuse him in situ. He'll just break the next one really quickly. So you don't have a choice in this matter. To do surgery, you have to do a PSO to stop the disease process. So where to do it? Obviously, you just do it where the calcified disc is L3. The optimal place to do a PSO is at L4. And the reason why you want to go as low down as you can to get as much correction as you can, because when you fix a crooked tower, you want to fix it down at the base because it brings you back further. Not that much, but more. If you do it L4, you'll have good screws at L5, S1, and ilium. So you have 3 really strong points if you can do it at L4. Or you can do it at L3. Classically, L3 is where most people did it, just because you could put screws at 4, 5, and 1. But now with the iliac screw, everyone puts in iliac screws. That's by far the strongest point. So you have to. So the PSO, pedicle subtraction osteotomy, should be at L3 and decompress. So it's kind of a simple problem, I guess, but it's really hard. So revision decompression at L3 and a PSO. So the best way, if you have you ever hear the rule of P's for surgery? Poor preoperative planning predicts poor postoperative outcome. Yeah. So you want to plan everything. I mean, obviously you don't have to, like today's case, I don't have to plan it because this is one of decompression, but this is in case you got to plan. Think about it. And then when you go in, you just affect the plan. So you don't have to think. So the plan was expose T10 to L5, remove the previous screws. The lower ones, L5, S1, it was plus minus. If it's difficult, if it's super easy, I'll take them out, but the bottom ones are going to be difficult because it's full of scar, or leave them in. I looked up the old operative notes, so I knew what screws they were, so I knew that they fit the screws that I use, which were the Q Expedium. And then the question is on the right, he doesn't have a bottom screw. The question is, should I put it in screw in the sacrum or should I just put iliac screw? So the iliac is easy if you know how to do it. It's very easy. You don't have to worry much about neurological injury or the trajectory, etc. You just put it down in the middle of the pelvis, and it's by far the strongest screw. So that's why I thought I'm just putting an iliac screw on the right. It can be, yeah. There's a fiddle factor. Yeah, it does increase operative time and maybe some muscular dissection doing that. And then, so you have to. The plan was to put a screw at L2 because you want to have a screw just above the fracture, the osteotomy site, But it's not going to be easy because we look. Remember, the pedicles are small and there's cement there, so you have to get through the cement. Hopefully, you can do that. So I definitely wanted a screwed L2. L1 was impossible. The pedicles were 5 millimeters. And then, how many points above? I chose 6 because I feel with 6 I'm safe. The fewer points, the less stress per point. So I felt 6 screws, 2 at each level, T10, T11, T12 will be sufficient. And then put cement in the screws. I'll show you that. And the PSO again we set at L3, and that will decompress L2, L3. And then flatten the table. So we start kyphotic with the table bent about 30 degrees, which we can do with the new Jackson. And then after we do the osteotomy, we flatten the table with anesthesia, and that will give us our reduction. And then I decided in this man to do quad rods. This is the first time I've done that, but it kind of makes sense. It's easier. This just shows how you do the osteotomy. You can thin out the pedicle. I don't do that. I just take it out with an osteotome. I feel it's faster with the osteotome. And then you can see on the left, you want to, I don't use a retractor, but I pack it with a 4x4. That will protect us, the retroperitoneal space, the psoas, there's nerve roots in the psoas, and also the segmental vessels. And then that's not the osteotomy. That's just if you just take the pedicle out. But I always do number 4 because um, basically 1 and 2 are really small osteotomies. The basic question is whether you do a 3 or a 4. And this is my drawing in the office. I always cut through the disc because then you got a nice fusion base. You fuse the front. And you want bone on bone, yeah. And you don't need that disc anyway. There was no disc, right? Yeah. So I always do that. So the operative time was 7.5 hours and 2 liters of blood loss, which I wasn't happy with that. Um, and my personal opinion is you can't go more than 8 hours. Like that's when you get serious, serious problems. This guy was sick to start. I mean, he had COPD, he was anemic, he had heart trouble. But and if you look at pedicle subtraction osteotomies, that's average. So the average time is about 7 hours, and the average blood loss is 2 liters. So we were exactly average. Um, it's just a very big operation. The complication rate is 100%. So in the literature, it's a 100% complication rate. And really, we didn't have a complication other than he was intubated overnight, which probably was more of a result of his pre-existing lumbar pulmonary disease. So this is just a side view, and you can see our screws and cement in the thoracic spine. And then this is not him, but a previous patient that had a long fusion from T11 to L4. And you can see the screws, the top screws in deformities have a tendency to pull out, and they're just weak. Most of these people are osteoporotic and weak. So this is his post-op X-ray, and you can see his lumbar lordosis is pretty good. Um, he's pretty straight now. Remember he was crooked up here at L1, L2, L3, and now he's basically straight. And here's the cement in the thoracic screws. Right. So this is the cement. So you can see the screw is fenestrated, it's cannulated, and it's fenestrated. It's got these tiny little holes. And then through the fenestration of the screw, we push the cement, and it's a glob of cement. So now, for this thing to pull out, that whole glob has to break out of the bone and pedicle. So on the one hand, I feel good that we have these really strong screws. On the other hand, I'm a little worried. What happens if these pull out? Yeah, it's a like serious problem. Um, and so this is just the steps. The steps is just place markers and then check both front and side views, and then insert the screws over the cannulated wires. And this is our T12 screw. We didn't put cement in T12. We just did cement in T10, T11. And these are L2 screws. They're bullseyes. Thank goodness they're bullseyes. Yeah. And here's L3 at the level of close to the level of the osteotomy. And you can see there still is a little bit of remnant of that posterior ossified disc. I couldn't get it all off. I mean, I don't think it's necessary. The thecal sac is fully decompressed posteriorly, so and you can see the 4 rods. And here's our iliac screw. It's like bullseye, and it hits right at the front of the pelvis. Yeah, so that's why when I measure it, I go down, I stop when I hit it because I know that's what I'm hitting. You can see the old S1 screw. And here's a side view, and he measures 7 degrees of lordosis, which is good. And the front view, you can see all of our bone graft at pedicle subtraction osteotomy area, and we packed some bone graft in the osteotomy, the area that didn't close. And here's basically the before and after. He was 18 degrees. Actually, he was a little more, but on that one where it measures 18 degrees kyphotic, and post-op he's 7 degrees. And you can see on the side view, now that that pedicle's gone, you can, you can crank him backwards. And there's no way we could have done this without removing the pedicle. So, yeah, we couldn't have, it's a lot better if you could have a flexible table. I mean, I don't know how you would do it without the table. What we used to do is we used to use transverse gel rolls, and the old operating tables that you do like appendicitis on, they bend. You can bend. They didn't bend it for spine. What they did is they bend it up, so people were sitting position to do shoulder surgery and whatnot. They can also bend backwards. So we used to just put them on jelly rolls, bend the table, and then straighten the old table. So we used to still do it, but it wasn't as easy. So So that's it. So he's like rehab now, and he stood up post-op day 3 or 4. He was standing and walking, and he's in a brace. So any questions about pedicle subtraction osteotomy? I think it decreases pain. It's comfortable to wear. It keeps you still, and it may decrease the probability of the top screws pulling out. Um, it is uncomfortable. He didn't like it very much, but I feel obliged to do the brace because if his screws pull out, then I could say maybe I should have used a brace. So 2 or 3 months, let the fracture heal. So what else? So what are any questions about pedicle subtraction osteotomy? When to do it? Lumbar lordosis. Why flat back deformity is so common? Because we all have germ disease. Basically, we fuse in situ usually. Yeah. What do you think of my explanation? Is BS? If you go to Smithsonian and go to the osteology exhibit and look at all the bones of the animals, which is like really interesting. You could look at all the spines; they're all lordotic. I mean, they're all kyphotic in the lumbar spine. All the rats, the dinosaurs, all of them, and they're almost. It looks like the same bone, really. It's just a little bit shaped a little different. We're the only ones that have that lordosis, and we're the only animals that walk upright. It's interesting. It's interesting to look at the gorilla and the chimpanzee because they're very similar, but not exactly like us. Yeah, yeah. So they're kind of straight if you look at them, but they're similar to us. Yeah, natural history. It's a great exhibit. I mean, I've been there maybe 20 times. It's really, really good. You really enjoy it, and it goes through orthopedics. It's a great exhibit. It's been there since I was 3 years old, 50 years, and they've improved it a little bit, but it's basically the same. Yeah, it's really, really good. All right. So any other questions about pedicle subtraction osteotomies? Okay. Thanks for coming.